So today we've got a lot of excited people that are going to talk to us about low tech, high yield, innovative bedside teaching. We are all in the game for being able to share information. I'm going to let all of these wonderful ladies introduce themselves. So I will give you the opportunity to take it away. And thanks so much for coming to us today.
Thanks, Cynthia. Hello, everybody, and welcome to our presentation on low-tech, high-yield, innovative bedside teaching. We will share examples of teaching strategies that will require minimal technology, time, preparation, such that they are easily accessible to all our teachers. The group of us represent a spectrum of emergency medicine physicians ranging from resident to fellow to faculty. I'm Dina Knies, and I'm a medical education fellow at the University of Michigan, headed to UT Health in Houston in July.
I'm Haley Andre, and I'm a critical care fellow at University of Colorado.
I'm Mallory Davis. I'm a third-year emergency medicine resident at University of Michigan.
And I'm Mary Haas. I'm one of the assistant residency directors at University of Michigan.
And I'm Meg Wolf. I'm at the University of Michigan, and I'm the Med Ed Fellowship Director. We're so excited to have you guys here with us today.
So the ED environment is one of the biggest barriers to clinical teaching. I know I'm preaching to the choir here, but we all know it is chaotic and unpredictable. We have so many competing demands with regard to patient care, meeting metrics, managing flow. And we have very high acuity patients that can come in at any time. This makes it difficult to prioritize teaching, and we are already spread quite thin with regard to cognitive load. The ED learning environment also often lacks the same type of structure that facilitates teaching moments on the wards, in the OR, or in an outpatient clinic. In addition to the ED environment, there are several other barriers on the faculty side. Most faculty have not had formal training with regard to clinical teaching and may lack skills or confidence in their skills. They may feel insecure due to the perception and unrealistic expectation that the teacher be omniscient. They may feel it is not worth their time due to underappreciation of clinician educators for the effort and time it takes to do clinical teaching well. And there also isn't a ton of research out there about which techniques work the best because it can be quite difficult to study. On the learner side, trainees may be complacent and afraid to speak up and ask for more teaching, especially as they realize the many competing demands of the ED environment. Despite these barriers, it can be done, and the benefits are many. We are glad you are here so that we can share and maximize with you strategies to integrate clinical teaching and educational experience for your learners. Although there are barriers to clinical teaching, many of the same aspects that make it challenging also provide opportunity. For one, we see a huge variety of pathology, both medical and surgical, with enormous breadth of patient presentations. We see high volumes of patients relative to other settings, leading to a higher number of potential teaching encounters. With our patients who are acutely or critically ill, learners are more likely to encounter abnormal physical exam findings that can be pointed out and discussed by faculty, providing opportunities for teaching moments. We do procedures in the ED, which often offers the opportunity for procedural teaching not commonly present in other situations or settings. One thing to note is that there is often the perception and concern about faculty that increasing teaching will diminish teaching will diminish time to do other things. At least one study has demonstrated that medical students do not perceive an inverse relationship between teaching and productivity, and that there are faculty who can provide excellent teaching and attention to patient flow simultaneously, but that it requires faculty development to develop those skills. On an individual level, it requires a desire to improve one's own skills. On a department level, it requires support and acknowledgement of teaching and the educational offerings needed to develop faculty with the motivation to improve. So why does this matter? Excellent clinical teachers improve learning. Clinical teaching that happens at the bedside allows teachers to demonstrate skills and model behavior, including physical exam skills, patient and team communication, and professionalism. Additionally, clinical teaching allows for direct observation of knowledge and skills, including otherwise hard to teach and measure competencies like interpersonal skills and communication. Direct observation is the holy grail for assessing learners and allows faculty to provide specific, actionable, credible feedback based on what they observed. This is the type of feedback that catalyzes learning, not the good job today or read more read about your patients when you get home that is most commonly given. If done well, clinical teaching at the bedside can improve the therapeutic relationship and patient education. So next, let's share some strategies with you to put in your clinical teaching toolbox. Let's get into some practical techniques you can apply in your next shift. This first one is the indirect observation, in which the attending surreptitiously observes the resident's, patient, and staff interactions and care plans. This allows you to get a feel for what it looks like when you're not in the room or running the show. Talk to nurses and other staff. Dig into the chart to see what labs and imaging have been ordered. Round on the patient separately from your resident. Even observe quietly from behind the door or curtain. This is a great way to balance autonomy and attending comfort in situations where this can be particularly tricky. Next is strategic questioning. This is the use of the Socratic method to pimp without really pimping. The goal is to use questions to find knowledge gaps to facilitate discussion and get your resident to the next level, not to highlight failures or create resident discomfort. Make it clear to your resident that you'll ask questions for this purpose, so that you can create an interesting and educational discussion tailored to the topic at hand and the level of your resident. For high-level residents or too basic or easy patient scenarios, use the what-if game to create that appropriate level of difficulty. For example, the case may be an incredibly straightforward diverticulitis, but you can create opportunities for education by modifying the circumstances by asking questions like, what if this patient also had an abscess? Or what if this patient had an allergy to Augmentin? What antibiotic could you use then? And now let's hear from Haley about SNAPS.
SNAPS was developed in 2003 as a learner-centered model for case presentations to preceptors in outpatient settings. It works really well in our setting, but you have to go over this model with the learner before you use it. This is a 6-step model that walks learners through their clinical reasoning and into the plan, and then into developing learning goals based on the gaps identified. The steps are first to summarize the history and findings, then to narrow the differential diagnosis, analyze the differential diagnosis by comparing and contrasting, then probe the preceptor by asking questions, then you move to plan management, and finally, you select an area for self-directed learning. This works really well with medical students, and we like to use this with our early medical students rotating with us in the emergency department. The next technique is called the 1-minute preceptor. It's a series of micro skills that you can use while staffing your learners. This approach was first described a few decades ago and is still very valuable. For this one, your learner does not have to do any pre-work, and many of you are probably using pieces of this and don't even know it. The steps to the 1-minute preceptor are first to get a commitment, make the learner make a decision. Next, probe for supporting evidence. Ask them how they got to that decision. Then reinforce what was done well, whether it's the decision-making, the patient encounter, interacting with other staff members, then give guidance on any errors. And finally, use this opportunity to teach a general principle. If you don't have anything to add for the learner about the particular case, this is a great opportunity to teach about the resources that you use to do more self-directed learning. The next tool is teaching scripts. This framework trains educators to react to a trigger, an identified area as a knowledge gap, by highlighting specific high-yield evidence-based teaching points and selecting teaching strategies to incorporate into a brief script. By having these scripts created in advance, clinical teachers will have a repository of literature and creative tools to teach on common clinical issues whenever teaching opportunities arise. These should be very short scripts, no more than 2 minutes in our clinical setting. The anatomy of a teaching script is to identify the trigger, and then have your key teaching points, including some visuals, and then be able to customize it to the learner's level. Some common examples of triggers that we run into in the emergency department are common clinical scenarios. Think your middle-aged man with chest pain. Also high-risk situations, when we need to rule out a PE is an example of that. Also, common learning challenges are great situations to have a teaching script for, or any situations that puzzled you as a learner. It can be helpful to think of things you see all the time and what teaching points you want to make about them. Can you customize them for a different learner level? One example that Dr. Wolf likes to use is this discussion of the PCARN rules when a learner has seen a child with head trauma. Now I'm going to hand over to Mallory Davis to talk about Post-it pearls.
So we'll start with Post-it pearls. Many of you may be familiar with the Post-it pearls technique, which was popularized on Twitter and Instagram by educators Michelle Lynn and Rob Cooney. Teaching points pertinent to patients seen on shift can be written down and placed at a shared workstation or another convenient central location. Learners can take the notes home at the end of a shift, or it can be left behind to spark conversation and teaching after you have left the department. They can easily be transmitted into a digital format and shared as FOMED content. Illustrations can be helpful to highlight the teaching point, and citations are useful for learners to do further self-directed reading after shift. The advantages of this technique are its versatility. It works really anywhere. All you need is a pocket full of Post-it notes. The size does mandate that the teaching points are short and quick. You can use a Sharpie marker to enhance this aspect. This can also be a downside. You are limited in how much you can write by the size of the Post-it. Also, if you have bad handwriting, like many of us do, it can also limit the utility of this approach. If you forget your Post-it notes, don't let that stop you from using this technique. You can get creative and write your learning points on whatever you have available, like whiteboard paper, printer paper, or even a bed sheet, as one of our former University of Michigan attendings, Sage Whitmore, demonstrated here, teaching about the different types of respiratory failure while working in EC3, our ED critical care unit. Another great opportunity to share pertinent in-the-moment pearls with your learners is through just-in-time teaching. I've often found it most useful in regards to teaching procedural skills. Taking a few minutes prior to the procedure to discuss things like indications, complications, the procedure itself, and next steps can be an effective way to provide teaching points while also ensuring safe patient care. This can also be used prior to a resuscitation for which you've had advance notification, like a trauma activation from the field. It can also be a nice opportunity to follow up the encounter with brief feedback or a debriefing session after observing the learner-patient encounter. Finally, a high yield and quick teaching technique is incorporating board review into your staffing encounter. There are a few different ways to effectively do this. Some providers, like Dr. Will Moyer from University of Michigan, do this by encouraging learners to answer a question from a board review flashcard set prior to staffing each patient. Another way this can be effectively done is by reviewing a patient encounter from the day with an interesting teaching point in an oral board style case during sign out. The oncoming team works through the case and the offgoing team provides the pertinent information. This is most effective when the teaching point is summarized by the offgoing senior resident or attending, and is a quick and effective way to review high yield learning points and practice attacking oral board cases. Next, we're going to discuss opportunities to get innovative with how you staff patients. This is beyond the serial kind of traditional trainee attending staffing model. This can enhance opportunities for teaching. So when we think about the traditional model of staffing, the trainee evaluates the patient and then presents the history, physical exam, assessment, and plan to the attending. The attending then goes and sees the patient and then revises the assessment and plan and discusses this information with the resident. For the first method, which is called the parallel encounter, the attending physician and resident see the patient independently. The resident does not present the history and examination to the attending physician. After the attending physician and the resident evaluate the patient separately, they then come together to discuss and formulate the assessment and plan. This has advantages such as allowing more time to discuss the assessment and plan without focusing on clinical reasoning. It also allows for integration of two independent assessments of the patient. This can reduce the likelihood of diagnostic momentum, premature closure, and confirmation bias. Also, the attending physician can evaluate the patient at any time, which may enhance efficiency, patient satisfaction, and outcomes. This reduces the initial time to provider contact. But to protect resident autonomy, this attending must combat the urge to place orders or explain the care plan to the patient prior to the joint discussion with the resident. A few disadvantages of this technique is that the model may disadvantage junior learners who require continued practice of the traditional oral case presentation, and some learners may also prefer to verbalize the patient's history and examination to synthesize clinical data while formulating an assessment and plan. The next teaching method is called teacher as scribe. The resident reviews the patient's chart, the resident and attending enter the room together, the attending states their roles and explains the encounter to the patient. The resident then performs the history and physical while verbalizing exam findings and explains the assessment and plan to the patient. The attending observes and simultaneously cross-references the chart, inputs the history, physical, and the initial assessment and plan. And then they can also order the orders that are verbalized by the learner. Some advantages to this are that it eliminates a separate evaluation. It reduces separate time to order entry and results. It also can facilitate some real-time documentation by initially entering that history, physical, and assessment. It generates a shared mental model with advantages of timely documentation, and the teacher can also model behavior, demonstrate techniques, and provide indirect feedback through follow-up questions and exam maneuvers at the end. A few disadvantages of this technique is that the learner may be apprehensive about being watched or suggesting a plan to the patient without any prior discussion with the teacher. The teacher must also avoid unnecessary interjections, which would sacrifice learner autonomy. Now that you've learned about several ways you can easily integrate clinical teaching, let's discuss some general strategies to help you moving forward. The first is be prepared. Have teaching scripts and strategies in your back pocket so you can pull them out when the moment arises. You can have different teaching scripts for different levels of learners for common chief complaints. Attending this presentation and having awareness of these teaching tools will also help you be prepared to convert an encounter into a teaching moment. Secondly, know your team, know your goals. At the beginning of the shift, make sure you know the names of your learners, a little bit about them, and their goals for the shift or the rotation. This can help you tailor teaching. Also, display an enthusiastic, non-threatening tone at the outset of your shift in order to set the right tone for the rest of the day. Also, choose the right time to teach. Resuscitations can be great teaching moments. Obviously, patient care takes precedence, but having teaching points prepared around airway assessment, shock, rhythm analysis can be very helpful. Even if they can't be shared in the moment, they can be taught afterwards during a debrief once the patient is stabilized. Limit the amount of time per patient. You can use strategies such as a 1-minute hallway lecture to provide context to learners about the patient's chief complaint or pathology prior to entering the room. Limit the amount of time spent within the room to roughly 5 minutes where possible. Also, set realistic expectations for yourself. Start low and go slow. Avoid having too many learners working with you at once in the beginning so that you are not spread too thin. Choose 1 to 2 high-yield topics or teaching tools to integrate into teaching and build from there as you gain comfort. Also, be professional. Remember that you are being watched by the learner, and your words and actions reflect how they conceptualize the culture of EM and the House of Medicine in general. Even when not explicitly teaching, trainees are watching you work as you are modeling behaviors. Avoid speaking negatively of patients or using terminology that could be seen as denigrating, such as hot mess, train wreck, gomer, things we've all heard on shift. Employ collegiate communication with consultants, staff, and patients. And finally, train residents how to teach at the bedside. They can be an invaluable asset to teaching medical students and other members of your team. I'm going to turn it over to Drs. Haas and Dr. Wolf to discuss questions.
Thank you so much for that awesome recap of some strategies that we can all easily integrate onto on-shift teaching. One of the things we were excited about with this presentation is that we figured a lot of the people who attended would also be people who are also passionate about education and will be able to share their own tips and tricks and their own experiences with using some of these techniques and others that we may not have covered. So we want to open it up to the group and use the rest of the time just to talk about our experiences. And we've provided some question prompts here. Have you ever used any of these techniques, and what has your experience been? Please share any other techniques you may have, and how do you tailor your techniques to your level of learner? So if anybody has anything that they'd want to share, would invite you to unmute and share your thoughts.
And also, please put things in the chat if you prefer instead of talking.
Thank you guys so much for making sure we've got some low yield ways. I was hoping that some of those general considerations at the end, you wouldn't mind typing in the chart, because in the chat, those are some great ideas. I love the post-it note. Somebody else wrote in the chat that they moved the post-it notes around to where the different patients are so that you could learn something different. I was wondering, do you guys use color coding? Like, this is a research, or this is a clinical pearl, or this is something about vitals. Is there a color code to your post-it notes, or is it just whatever ones you have in your pocket?
That's an awesome. Oh, go ahead, Dina.
I was going to say, that's a great idea. I actually don't. And I think that I am embracing the simplicity of not creating a system anybody has to learn or keep track of. As shift change happens and the new team comes on, who knows if they remember the colors that are supposed to be this or that thing. And so I think the simplicity adds to accessibility and encourages people to join in and be part of that too, so that it doesn't belong to me or my team. Anybody can be part of that. So I don't do that. But if you've got a team that's willing to stay organized and committed to that, I think that's a great idea, especially if you are going to then go share it on social media later. If this is something that you very consistently do, I think it's worth it. If you're not very consistent about it, or if your shop is not very consistent about it, I don't know that it adds a lot.
Dina, could you comment on in the chat, you had talked about using or your attendings doing the note writing that way. Can you just mention that?
Yeah, so as an early to mid intern, I struggled with being overwhelmed by all the information that I was presenting. I had all of it, and sometimes, if it wasn't a very clear picture, or sometimes it was a clear picture and I just wasn't seeing it, it was hard for me to pull it all together at the end and synthesize. And rather than spend a lot of teaching time trying to coach the resident through that, you can probably circumvent that by having the resident write their note, and the structure of the SOAP note will force them to get organized and force them to sort of lay it all out in front of themselves. And so that way, the organization of the note helps them create some organization in their mind and creates a clearer picture, so that they can come with a reasonable care plan to the table that you may then modify, but you've skipped having to teach them through the untangling of all of that information. Writing the note will do it for them, or at least get them most of the way, and they have to write a note anyway, so 2 birds, 1 stone. And I also found that it made for a much smoother and more comfortable interaction with my attending, who then was not getting frustrated with me. So that was my experience. I think it worked really well. When I have a resident who I see doing that same thing, I just ask them to write the note first. I find it works better with junior residents, and then with senior residents, I have them only do it if it tends to be a very complicated, murky situation where the information was hard to obtain or was not clear, and that can help.
Thanks, Dina. That's so helpful. There's a question in the chat from Dylan. I love this question. It says, I'm an incoming PGY1, and how do you recommend starting to teach when you're busy and you're an intern and kind of all of those things? Haley and Mallory, I wonder, you guys are the closest to this. If you could kind of comment on, because you're both excellent teachers, sort of how you went about doing this.
I think that one of the tools I like to use a lot early on was the development of teaching scripts. And you'll find that you actually know quite a few teaching scripts because they were the ones that were given to you as a student. And you'll see that many of your learners will fall into the same, have the same knowledge gaps as you had when they're staffing a patient with you. And then you can use those teaching scripts to give very quick teaching points to those learners. And you probably already know them.
I think one thing too that you can get very busy and bogged down in your own work and trying to focus on your own patient care, which is the point of, you know, being an intern and being a resident. And I think that having the med student come up with a topic and have them look it up so that they can teach you, or that you, and then you can have a discussion about it. So that occupies their time. Not that you're trying to, you know, unload them, but that way that then you can have a kind of a fruitful discussion where it's not you just teaching the whole topic, and that they can teach you something, and then you can also kind of fill in the gaps that they're missing. And that way you just have to find time for it, but that way it's not spending your whole time teaching a whole topic, unless it's kind of what Haley was talking about, a quick like 1 minute teaching script.
Yeah, I have a question about your 1 minute. When you talked about the 1 minute preceptor, how do you do that when you've got a senior resident who's got a med student with them and trying to make something applicable for that wide range that potentially you might have?
That's a great question. And I think one of the most common questions that come up is, how do you customize your teaching to this broad range of people? And I think sometimes we can get into this a little bit of a pickle because we're trying to be all things to all people. And so I don't worry about getting all of the people all of the time. You know, so if I'm like teaching both a med student and a senior resident, I make sure that I have teaching points for both of them, but they're probably not going to be the same teaching points. And that's okay. And sometimes, you know, if there's something that we're teaching about and I know the senior resident is going to have information about it, I will invite them to share first and then might add on to it. And so I think that can be sometimes one of the barriers is just trying to feel like it needs to be perfect. I see somebody also wrote in the chat about adjusting their teaching focus based on how busy we are, who I'm teaching, and also it's the first few hours of the shift versus close to the sign out. And I think that's like another great reminder of, you know, this is going to be totally different depending on how busy it is, where you are, who you're teaching. And it doesn't need to be perfect every time. The goal is just to try to do it when you can. I don't know if anybody has anything to add about the different levels of learners.
I think that one thing that I've found very helpful as a learner as I went through the different stages of learning. So when I was a med student or intern, lower level resident, I was learning more about the medicine, the facts of the care we were providing. And then as I progressed to a supervising level, I was learning more about what it was to be a teacher. So some things that were very helpful were instead of me being the one who was receiving the information going through the 1 minute preceptor, actually doing that and then getting feedback on my teaching rather than the information that I was using to make care decisions.
Hey guys, I just wanted to thank you for this presentation. I think it outlines a lot of things I realized that were like different faculty were using with me as a resident that I didn't really realize in real time were specific teaching techniques. And as a new fellow / attending, I think it's a helpful reminder kind of as I get my legs under me from a staffing standpoint, ways to be creative. One of the things I realized about the scribe model of staffing is that it's also kind of a unique way to get documentation and feedback. I have a really specific memory of being like an early second year and having an attending who did that with me. and they didn't finish the notes, but they wrote like the HPI and the first part of the NDM. And I was a very loquacious intern in my documentation. And it took a few of these shifts where I would open the attending notes after the fact and read what they wrote on my patient and be like, oh, really? Like, that's it? That's what I can write? Oh, okay. Well, this is like amazing. This is making my life better. So I just thought that was really helpful as like an unanticipated benefit as well.
I agree. And I think that there's a specific attending that I think we both worked with, Dr. Michelle Daniel, who used this technique a lot when I worked with her, especially on overnights when it would be really busy. And it would be very helpful to also see like the questions she would ask, because a lot of times you go back and you staff and then they're like, did you ask this? And you're like, oh no, I forgot to ask this. And then you kind of just forget about it. But in the moment when the attending's like asking about these other specific questions, you're like, oh yeah, I should know about those things. Or like, oh, I should have thought about that. And then it kind of, I think, helps wrap up the encounter when you have them asking questions and like putting in orders that you maybe didn't think about. And then it's also very nice on a very busy shift to be able to knock out a bunch of rooms at once and have documentation partially done. So you don't end your shift and go, oh, great, now I have, 15 notes to write or whatever.
I totally agree, Mary. And it's a huge solidarity move to like pitch in some of the more menial aspects of our job when things are really crazy.
I think people also really forget that direct observation is so critical to teaching. I mean, I think a lot of people probably just don't even realize that it's as simple as standing behind the curtain and listening in and just paying really close attention to what your learner is doing. Because oftentimes we're really only making assessments on their clinical skills based on what they tell us in their presentations, and not actually from truly seeing what they're doing, how they're asking the questions, how they're taking a history, how they're explaining things to patients. So if you don't make an active effort to do that, they may never really be observed by faculty, and it becomes a lot harder to course correct if there are certain habits that then don't change that should have changed earlier, or that there's certain habits that would make their lives easier and their evaluations more effective that somebody could have intervened and taught them at an earlier stage.
Max asked a question in the chat about teaching scripts, and I know Haley weighed in on them, but the question is, how do you actually do this? Like, do you have something with you? Do you have a laminated thing that everybody uses? And I have seen it done a couple of different ways. I think it's most successful if it feels like it's your own. And so the first few times when I started doing this, I literally did just actually write them out first in script form and then in bullet points. And then kind of as I got into the routine of it, I don't actually write them out anymore. I just try to be really intentional about like, okay, when I'm teaching about this thing, these are the things that I feel like are the most important. And I kind of just internalize those. But initially when it's starting out, it can be really helpful to write them out. I don't know if anybody else has any suggestions about that or how they do.
I like to take things I've given a lecture about and convert them into brief teaching scripts, because oftentimes you have done a lot of the pre-work of learning about the nuances and the clinical pros in advance. And so if you've given a 15-minute lecture on a clinical topic and then you encounter it, it's easy if you can just kind of give a 5-minute summary of the things you talked about in your lecture. So if you ever do give a lecture on something, you can dual purpose that and keep that in your back pocket as a teaching script.
I see a lot of tips in the chat about bringing residents and medical students back into the room to go over discharge instructions or physical exam findings. I would like to know how you guys, some of you as very early educators, how do you inspire or push your residents to the want of being a better bedside teacher, and not only as a recipient, but those that are going to be turning around as an intern and teaching the nurse or the tech or the third-year med students in there? How are you guys encouraging better bedside, more effective bedside teaching with your learners so it's a 2-on-2 thing?
That's an awesome question. I think so much of it just comes down to role modeling. I think people are inspired to be better teachers when they see other people who are invested in teaching. At least I know that I felt that before. So just very clearly making it a priority to incorporate teaching on shift, I think is one of the most effective ways to encourage those residents and even students as they progress through residency to also want to be good teachers.
I think it's really important that you included the nursing staff and techs in that point, because I often like to remind residents that, you know, we're here not just as teachers for, you know, our learners, our medical students, our lower level residents, but also our patients, our nursing staff, our techs are constantly trying to learn more about what we do and the care that we give, and remind residents when they're getting like lots of questions from nurses about what's going on, that's the nurses trying to learn, and it's an opportunity to teach too.
I love what Mark said in the chat too, that if we as faculty are excited about even basic exam findings, which are often pretty cool, it can rub off onto residents and students. And I think that points to the greater point that I think sometimes we don't even realize this, but as faculty, we really set the tone, the attitude we're bringing on shift, the things we prioritize. I mean, that really rubs off on the entire team. So if you have a positive and engaged attitude toward teaching, it's going to inspire others on the team to want to do the same.
It's one of the really special things about our field is that it really is a team sport, and we are the team captain. So just trying to be excited, and then when you do see your learners teaching each other at the different levels, really just giving positive feedback for doing so.
I wanted to take advantage of all the awesome educators I see in our participant list. Are there any cool techniques or maybe even things we covered or things we didn't cover that you do very frequently that you could share with us?
I will say we just added a whiteboard outside of our critical care area, akin to the University of Maryland, where they step out and they're doing chalk talks. It's been it invites conversation. We'll come over here, let's just talk about that. And sometimes they want the residents who were involved with that particular case will grab a couple of the others. Come on, let's go talk about it. And as soon as you know, there's 5 or 6 people gathered around the board for 10 minutes, just trying to get what the concept was. So, although we stole that completely from whoever else is already doing chalk talks, I think it's been a great addition to our ED.
One thing I've noticed too, we have a whiteboard at one of our sites, is that it's helpful in the moment to go through things, but even when the whiteboard's been up for a few days, people will ask questions about it, even like when we're signing out or just walking by the whiteboard. So it spurs discussion, you know, days after the initial time that they've put it on the whiteboard too, which I think is kind of neat.
Are you guys looking at the chat? It says, I will regularly rewrite resident notes and send email feedback with original and revision and discussion about why elements were changed. Please comment, because boy, if I could even get my own notes done without trying to rewrite the resident notes, you know.
That was my first reaction to that. I am really impressed with that. I think that does highlight, though, that really any touch point you're having with a resident or in patient care can be a teaching point. And so if you are needing to go through and rewrite a note because you just need to do all that, yes, make that into a teaching point and give that feedback, because that's going to be pretty powerful.
I love that. I actually do that for almost all the interns in the beginning of the year. And a lot of them will tell me that it's the only time they've ever received detailed documentation feedback. So I know that they really appreciate it. And I think it helps get around the other barrier of how busy we tend to be on shift. If you can give yourself a little bit of leeway to do some of your teaching after the shift when you're in a fresher state of mind, it can really help incorporate that in a way that's like a little bit more realistic sometimes for those super crazy shifts. And not only taking it as an opportunity to provide documentation feedback, but including additional clinical pearls that you thought of after the fact, follow up on the patients you saw. Hey, I saw this patient did this, and in retrospect, this finding could have predicted that, or, you know, something related to the case that you saw in the follow-up, or even a, you know, a PubMed resource for something evidence-based that relates to the care that you gave, I think can be super helpful. So that post-shift email, I think, is a powerful teaching tool in itself.
Another shout out in the chat that this is a helpful thing, because Max mentioned at a residence we don't get enough feedback about documentation, and that is so true. And Dina, I also see you mentioned doing like fill in the blanks on the whiteboard. That's an interesting idea too. Oh. I'm glad it didn't freeze when you were presenting your slides, Dina. We know you're here. You continue to be here with us.
I don't know if you said anything to me. Everything froze. I'm sorry.
I'm also so happy to see so many learners in the participant list. And I think, and I know several of you already have provided your perspective about what teaching aspects you found most useful, but I also just want to invite any learners who have other thoughts about things they've seen from the learner side, their faculty too, that have been particularly meaningful or impactful.
I know this is supposed to be low tech, but do you guys incorporate it all, telling your learners to look that up or do, you know, talk to up to date and then come back? How are you incorporating some of the simple low tech, as in their phone, into your teaching so that they are learning how to incorporate those things?
A really cool way that we've talked about a couple years ago at SAM was the use of Google Docs on shift. I think that is a great way to set up a learning document for the shift. You can create it, share it with your learners at the beginning of the shift, and then everyone who has access to it can add in learning points about the patients that you've seen. It's a great opportunity to have the resident or medical student go look up something on UpToDate and type a little summary of what they found with a reference. And then everyone can have it to review after the shift.
I love to use WikEM online. I use it multiple times per shift, and I love that it's in bullet point form. So sometimes when I'm staffing a patient with something that doesn't come around that often, or a patient presentation that offers some good teaching points, I'll actually just search it on WikEM and use that as inspiration for an in-the-moment teaching script. And we just kind of go through the content in bullet point form that's on there together. And it's great because I already have the highest yield pearls curated for me. I can search it. It's very quick. I get to review things for my own learning. And, you know, I think it also role models the importance of trying to read around your patients, including it real time to your learner.
I also will go over some of the, like with med students or junior learners, some of the apps that I have, like PDStat, Safe Local. I have MD Calc on my phone, and it has like the starred things that I use a lot, like the Heart Score or like Perk, things like that. There's things I think a lot of us have that we don't think about that other people don't have on their phone, and you can quickly pull it up and show them the app and like how you use it. Just for example, with like different patients that you're seeing.
That's really great, Mallory. And I love that kind of like modeling of how you do your self-directed learning and give them tools that they can use in the moment. I think all of these things that come up on shift are opportunities to help them in their development as a self-directed learner, because this is often something that people struggle with when they are out of residency and suddenly they're trying to figure out how they keep up on all this stuff themselves. So incorporating all of those things in real time is really great.
I know we have about 5 minutes left. I was wondering if each one of you could think about a high yield last fact that you'd like to put in as we are building a list? I see Mallory, thanks so much for going back and putting those general strategies in the chat. But if everybody could come away with maybe your highest high yield, low tech, as we go away and have some takeaways, that would be awesome. Haley, you want to start?
I think that I personally use teaching scripts a lot. So just having those things ready for the common things you see, whether it's chest pain, you know, a trauma patient, the like things like that, abdominal pain, those are really important that to have in your repository and then pull them out when needed.
Mary?
I would say to recognize that direct observation, even though it seems really simple, just standing back as the attending and watching your resident either in a normal room while you're scribing or in the resuscitation bay, letting them kind of run the show. I think that that is a really critical teaching tool because it allows you to give better feedback, and feedback I think is at the heart of learning and teaching.
And so hard to do. You're sitting on your hands for sure. Meg?
I think just remembering that really anything can be a teachable moment, and you don't need to have a fancy approach. You know, we talked about some like specific methods, but really if you are engaged and you are watching them and you are listening and you ask them what they're learning on, anything can be a teachable moment.
Mallory, you gave us all the general stuff. What about you?
I think one thing that we often don't think about, but can be a really great time to give some feedback is after resuscitations, after procedures, just taking a few minutes to discuss what went well, what could have worked better, can be a great opportunity to teach and use some examples from what, you know, just happened from the prior procedure or resuscitation. And that's something that can easily be done. It doesn't take a lot of time. It doesn't take a lot of resources. And I think that that's a great opportunity to give some feedback.
Sure. Dina, I'm scared. I hope your computer doesn't crash if you try to give some information. You want me to read what you put in the chart in the chat? Setting expectations is a game changer. I literally do it for everything. What role will you have in a code today? Take me into patient rooms if you think it's going to be an easy discharge. Remind me to complete an eval with you 1 hour before the shift in. I always do student evaluations with them, always. They love it, tailored to the resident and saves a lot of effort. Thanks for the thanks. Dina and I go way back, and I love that she's continuing her educating of the educators in a grown-up role for sure. Any last words? We've got about a minute left. I will say the only other thing I do that you guys don't, which maybe it means I'm doing a bad thing, I sometimes give like a 5-minute homework. Like if I know I'm going to be working with them the next day, you know what? Why don't you just go home and tell me exactly what is the difference between specificity and sensitivity, and explain it to me tomorrow so that when we're talking about the D-dimer, we can be very specific on how it means. Every once in a while, I do that, but it didn't come up. So maybe I'm being horrible by giving people homework.
That's a great idea, Cynthia. I love it.
Cynthia, thank you for being a fantastic moderator.
You ladies are hardworking and changing the world. So thank you so much for putting time together to do what we do as educators, and you're trying to make us better. So thanks again for the work you put in. Everybody have a great afternoon. I'll see you at your next session. Thanks.